Great. Well, welcome everybody. Thank you for joining us this afternoon or this morning or whatever time zone you're in for this collaborative session on innovating data collection methods for improved Latino representation in public health. That is a mouthful. But really what we're here today is to have a conversation on what Latino representation looks like in data collection methods. Before we go into the pan con café, it's not bread and butter because I don't like bread and butter, but I say pan con café. We just wanted to do a quick acknowledgement to our funders. This project is supported by funds made available from the CDC, National Center for State, Tribal, Local, and Territorial Public Health Infrastructure and Workforce through Cooperative Agreement OT 18-1802. So just thank you to our funders for this opportunity and for allowing us to be able to really work through the work that we've been doing in the past few months. So just a few housekeeping items just to help us have a smooth conversation today or smooth presentation. Just a quick reminder to please keep your line on mute during the presentation. This allows us to reduce any background noise and we can hear our presenters and that full discussion that we'll have today. We would really love to see who's here today. We'd love to see you on your cameras, but obviously only if you are in an environment to do so. But feel free to turn on your cameras. It would be really great to see you all here. But again, you know, if you're comfortable with it or if you're in that space to do so, we do have tech support from the MLU side. So if you need any assistance, please feel free to raise your hand and somebody will support you. And as mentioned earlier, this session will be recorded and we will be sharing this to all of our attendees through a YouTube link. So please be on the lookout for that after this session. And we will be taking questions at the end. So please hold your thoughts, or if you would like to just post the questions in the chat, we'll be collecting them as they come through and we'll be addressing them towards the end of the presentation. All right, so here's just a quick agenda in terms of what the run of show is for today. So just a quick introduction of who we are. Then we'll be turning it over to our phenomenal featured presenter, Dr. Midstarfer. And then we'll go into some case studies that we did throughout the COVID-19 pandemic. And then we'll get into question and answers. In the meantime, we'd love to see who's here again, what your name is, your organization, and your role within your organization. So please, if you can, put that in the chat. This also helps us know who's in the room. Right, so just a quick context of who we are, some background of who Maryland Latinos Unidos is. We are a byproduct of the COVID-19 pandemic. So Maryland Latinos Unidos was established in 2020, really to bring together and convene work across the state around supporting Hispanic Latinos across Maryland, really trying to address the gaps and disparities that our communities were facing. We were convening this collective to unify our voices because our motto is Juntos Podemos Más, together we can do more. Our mission is to call attention to the disparities that our communities, Latino and immigrant communities face, find solution and address this problem through a collective action. And our vision is a world where your zip code does not determine your lifespan. And so this is who we are. This is our awesome staff that may or may not be on. There's only a few of us that are here. We have a couple of folks out of the office traveling and doing all the fun stuff as this weather is getting nice and warmer. But my name is Kelly Velázquez-Umaña. I am the Senior Manager of Operations and Innovation. This is an outdated title. I forgot to update that. But my pronouns are she, her, ella, and our executive director and our field is your Doctora Gabriela Lemos. We also have our senior program manager for health equity programs, Walter Sava. And then we have Kimi Ortiz-Tai, who is our community health organizer. So our goals and objectives today is for you all to walk out of here with a understanding and knowledge on the importance of Latino data representation for improved public health outcomes. We'll be walking through data trends and exploring nuances around the Latino health paradox, which may be a term this is your first time hearing, or you've heard about this before, but haven't really delved into that space, and contributing those and how they contribute to factors and potential solutions. really looking at data collection from a health equity lens to examine the disparities and that our Latinos face through and how that looks like in data. And then also looking at some effective boots on the ground data collection methods tailored for our Latino community and their specific needs and context. So without further ado, I want to just, a great friend of mine and just a phenomenal human being that I absolutely adore and look up to so much, Dr. Mary Mitzstroffer. He is an assistant professor at the Joseph R. Biden Junior School of Public Policy and Administration at the University of Delaware, with primary research responsibilities in the Center for Community Research and Service. Prior to her academic career, she worked as a community health practitioner for a national nonprofit in the Mid-Atlantic region of the United States, where she worked with communities in the implementation of nutrition education programs in schools and cornerstones, as well as on youth leadership development initiatives. Dr. Mitzstroffer completed an interdisciplinary PhD in childhood studies at Rutgers University, where she focused on structural and systemic inequities caused by interior immigration policy and resultant disparities in educational outcomes among Latina children. She completed her postdoctoral training at the Institute for Critical Race and Ethnic Studies at Lehigh University, focused on systemic factors, organizational practices, and policies, and individuals' social histories influence health and well-being using mixed methods techniques, including community-engaged research and quantitative analyses. Her current research focuses on social and urban policy, concentrating on the nexus between the urban environment, adolescent mental health, and educational opportunities, and how such factors overlap and affect life's health and development, as well as issues of socio-demographic measurement among minority populations. All right, it looks like there's somebody who's not on mute. Just a friendly reminder, if folks can please mute their lines, that would be super helpful. Latina and how they impact accurate identification of health disparities and the implications that mismeasurement and misrepresentation have for life force health and development. Dr. Mitzstroffer is currently the vice president of the Latino Caucus for Public Health and has a special interest in helping to diversify the field of public health through education and mentorship. Thank you so much, Dr. Mitzstroffer, for joining us today for this collaborative session. I'm going to turn the floor to you. I'm going to stop sharing my screen and feel free to start sharing your screen.
Great. Thank you all so much for having me. I think I sound way more impressive than I actually am in real life. But I'm excited to be here to talk about a topic that's really, I think, important to think about. A little bit of a disclaimer, we're going to be focusing on the Latino population today, but I think many of us can see a lot of these same threads of having heterogeneous populations within the United States being bucketed or clumped in a way that may hide or mask health disparities, right? So I think that this could be really applicable to other areas of research as well. I wanted to give a few acknowledgements. We have a piece coming out in the American Journal of Public Health called De Donde Eres? Latina Identity and Representation in Health Statistics. So much of this talk and the research that is informing the talk comes from this piece. And I want to say thank you to my co-authors, Dr. Ana Michelle McSorley, Dr. Jose Perez Ramos, and Elizabeth Rojo. I also want to acknowledge that this work stands on the countless scholars, practitioners, and allies who advance this work over time. What I'm presenting to you is because other people exist and I stand on the shoulders of giants. And so I want to acknowledge, everyone's efforts in this. I am not the most brilliant person in the world, but there is a wide and diverse literature out there that we can all explore. I want to thank the Latino Caucus for Public Health, where I'm a vice president, and just all of the opportunities they have given me. I would encourage folks to take a look around. If you're looking for a professional home, it is a professional home that I think many of us on this call home, and it's really a supportive place. I want to thank Kelly Velázquez-Umaña and Maryland Latinos Unidos for this opportunity to share my work, as well as to share some things that I think are really important to think about within public health, but specifically within the practitioner space of public health. I think so often there is a divide between the academic space, the practitioner space, and we don't understand sometimes why we need to work more in concert together, why these facts are important in both realms in order to advance health and health equity, if it's ever actually going to be achievable. So today we're going to be talking about Hispanics or Latinos or Latine or Latinx, right? We go by very many different names. Oh, I should have said my pronouns are she, her, and ella. And also, if you are visually impaired or cannot see, I am a olive-skinned cisgender female. I have black hair. My background, there is some flowery wallpaper as well as some books and plants. So just to give you a little bit of a visual. So sorry about that. Today we're focusing on the Latino population. And when we talk about the Latino population, we're talking about people who have origins or whose ancestors have origins in Latin America. So this includes Mexico, Central America, South America, and the Caribbean. When thinking about this, we call ourselves a lot of different names. We might call ourselves Hispanic, we might call ourselves Latino, Latine, Latinx, we might call ourselves Chicana or Boricua, or a variety of different names. But we're all more or less referencing a group of people who are coming from a similar geographic destination. One thing in public health, as well as in research, that we tend to do is we tend to group Latinos as a monolith or one type of race or ethnicity. But Latinos, especially in the United States and throughout Latin America and throughout the world, are very different. Our population is extremely diverse, extremely heterogeneous. And so when we think about health disparities, when we think about strategies and interventions, we need to start breaking up this monolith, stop treating Latinos as a quasi-racial group and acknowledging the multidimensionality of our ethnic identity. And within our identities themselves, right? And we're going to get into that a little bit more, but Kimberly Crenshaw coined the term intersectionality in 1989, so nearly 35 years ago, which talks about the fact that we all have different intersections of our identity. I'm not just Latina, I'm also a woman, I'm also cisgendered, I'm also a professor, an academic. I live in the body size that I live in. I have the phenotypic features that I have, and it makes spaces receive me in different ways than even my siblings or my family members, right? Which ultimately informs and impacts health. Okay, so why should we care about Latino health? Well, it's not only important for Latinos, but also for the nation. We know that the United States is changing. Latinos are one of the only populations that has not experienced negative population growth, meaning that births have increased over time, displacing the number of deaths per year. So we know that the Latino population is growing, and this growth has really been contributed by the number of the Hispanic population that has been born, as opposed to narratives around immigration, right? So the population is young, it is growing. Nearly a quarter of all children in the US are Latino. And if you're in southern or southeastern states, it's roughly about 40% of kids, right? So it's important to think about our health, especially as Latinos make up about 20% of the United States population right now. And this is up from 16% in 2010 and projected to grow up to a quarter of the population by 2060. And so it's important to start getting health and health right. Previously in scholarship, something's been maintained called the Latino health paradox, which basically says that Latinos have the longest lifespan in the United States, pre and post-pandemic, right? And despite all of these social factors that happen, socioeconomic status, job, risk exposure, Latinos continue to live long lifespans, right? So this is seen as a paradox. But this paradox is outdated and arguably exacerbates existing disparities. What we know, Bowen and Humber came out with a study in 2019, where basically they find, yeah, Latinos do live longer, but they suffer in disease states longer as a result of that. And there's less intervention and intervention strategies applied towards the Latino population. And this is partially because of the ways in which we measure. And we're going to talk more about how we measure and how we group folks and intentional ways that we can think about measurement on the ground, as well as ways to challenge these outdated theories or to repurpose them in a different way. So right now, the average Latino life expectancy post-pandemic is about 78.8 years. Whereas the next ethno-racial group, so ethnic or racial group, I say ethno-racial, are white folks who are at about 77.6 years. So longest lifespans in the United States. So when I talk about a monolith, we're talking about a lot of people who are coming from over 30 different countries, very different ethnic origins. And if we take, let's say, birth outcomes, for example, Latina mothers and birthing parents are typically seen as better birthers, with birth outcomes closer to that of white parents and white mothers, right? So when we see infant mortality rates, for example, and those in the neonatal stage, Hispanic and white birthing parents have almost the same infant mortality rates. And what is very well established is that Black mamas have that of nearly twice infant mortality rates within birth outcomes, right? But when we begin to unpack the monolith, we see that this is not necessarily true. We see that when we look at it by origin group, or if we think about it in terms of the graph that I'm showing you here on the right-hand side of your screen, we have like Latinos in general, Mexicans within the United States, Central and South Americans, non-Hispanic white, and Cubans, right? And this is also still looking at infant mortality rates. And when we look and we see that Cuban mothers or birthing parents have lower infant mortality rates compared to Central and South American and Mexican mothers, right? So we see disparities starting to emerge, or infants rather, where we had not seen it before. And when we look at Puerto Rican infants, we see the mortality rate jump in a way that is closer to what we see in the Black population. So it's important to begin to unpack the monolith in a variety of different ways. We can think about it in terms of ethno-racial grouping. So where specifically someone may fall as Afro-Latino or Black Latino or white Latino or multiracial or indigenous, right? And how that impacts health and health outcomes. We can think about it in terms of origin group. So how one identifies, which is very difficult, right? If you have a bunch of different ethnic identities within the Latino population, but you know, if someone is Mexican identifying or Guatemalan or Cuban or Puerto Rican, right? Does this then change things? We can think about it in terms of generational status. I'm second gen, and so my health outcomes are much different than my mom who's first gen, right? And so on and so forth. We can think about it in terms of age, and we can think about it in so many different ways in which our identity plays out. But we need to start thinking about health disparities differently in order to begin to unpack this monolith. And arguably, this is applicable across different populations, right? It's not just the Latino population that there are hidden statistics, but we're going to focus on the Latinos today. So when we talk about equity, what we're talking about is not equality, right? So inequity is when someone's in position to receive a benefit where someone might not. And that's usually social or hierarchically a part or a remnant of society, right? And when we talk about equality, we're talking about everyone getting the exact same resource. So in the bottom left-hand side of the screen, you see two little kids on ladders picking apples. And one little kid has a ladder that's high enough to get to the apple, whereas another little kid has the same size ladder, but still cannot get to apples, right? So equality might mean that everyone gets the same resource, but not meeting the needs that we need to meet overall. Whereas equity is when everyone gets the tools or resources needed in order to meet their needs. So in this graphic on the top right side of your screen, you're seeing two kids on ladders, one with a higher ladder, and both are able to get apples. And justice is fixing systems to offer equal access to both tools and opportunities. So in this, we're seeing that not just the ladders are appropriate, but also that the tree is starting to get supports where it was bent before. So when we're talking about equity, we're not talking about equality. Equality measures are something that are really done within the United States. If you think about during the COVID-19 period, the first time that COVID-19 tests were sent out in the US mail, every household got 4 tests, right? So 2 packs, and in theory, 2 per person in households, which was totally great in a household like mine, where it was just myself and my husband. But in a household like my sister's, where it was herself, her husband, and her 3 kids, those 4 tests did not get to everyone who needed in the household. So choices had to be made. So that was an equality measure. It wasn't an equity measure. It wasn't meeting people where they're at. And so when we talk about health equity, what we're talking about is a fair and just system that allows people the opportunity to attain their highest level of health, meaning a system that meets people's needs where they're at and not where we assume they're at, or not where we're just distributing resources that everyone gets 2 of something, right? Because everyone might not need 2 of something. Health equity needs to be focused on historical and contemporary injustices. What I say, I sit in a public policy department, and what I say to my students all the time is that policy builds on a continuum, meaning that it's not that we're going to pass a policy tomorrow and all of a sudden all of the structural harm is going to be undone. Instead, it builds over time. So if you take immigration enforcement policy, for example, the very first remnants of immigration policy in this country were all about exclusion. The Chinese Exclusion Act was one of the first acts passed around US immigration, quite literally with the name exclusion in it. And immigration enforcement policy has always been about histories of exclusion and including select people. And that has built over time into the system we see now, right? So you can't just look at the cross-section of time that we're looking at now. We need to think about how policy builds and creates a structural environment that allows some people opportunities while disadvantages other people based off of their identity. There's also fluidity within identity too, of who's able to have opportunities. One thing I also talk to my students about is that if someone were Italian or Polish or Irish 100 years ago, they may not have been perceived as white then, right? There's a fluidity in the privilege and the opportunity that we have. And so these historical and contemporary injustices, yes, they exist, and they very much inform where we're at, but it's much more complicated than cut and dry, right? Who has opportunity, who does not. And so in order to achieve health equity, we need to be able to overcome these economic and social obstacles to health and healthcare. Our health, 80% of it happens outside of a healthcare system, right? It's the interactions that we have every single day. And so it's important that when folks get to the healthcare system, we have tried to meet the needs of folks in every way possible. So that way the folks who need it the most, who are in an emergent situation, are able to address what they need. And the folks who we may have been able to prevent things like spikes in blood sugar or the onset of heart disease, it gets caught early within intervention strategies by eliminating preventable health disparities. So the way I think about health inequities and equities is that we are a product of our structural environment, which means that we have our individual levels, our own personal beliefs and actions that either perpetuate or advance us or perpetuate our own oppression, right? So they're conscious and unconscious, they're internalized and externalized, meaning that like we all hold our own biases and they apply to ourselves and how we see the world. Then we have interpersonal interactions, which are the interactions between the folks that you see in your day-to-day life. It's whether someone receives you with a smile, or maybe the first time you meet a stranger, you get like the weird vibe from them, right? It's how we treat one another, which I think so often when we think about inequities, we're focusing on the person level. But really, we need to think about these institutional as well as structural levels. I adapted this from the lens of systemic oppression from the National Equity Project. So they had structural down here, but I think of structural as overlapping everything. So when we talk about systemic factors, we're talking about policies an organization or an institution has in place. So that might be a policy where a private hospital will not see you without insurance. Even if you're in an emergent situation, they have the right to turn you away, which directly impacts your health, right? Or it can be a systemic policy where a federally qualified healthcare center will always see you, right? No matter what's happening, you have access to it. And these systems overlap and they create inequities and they overlap over time. It's not just here in April 2024, these systems emerged and this is what it's at. And tomorrow it'll be a whole new system. So when we talk about structural environments, we're talking about these overlapping systems that reinforce discriminatory beliefs, values, and distribution of resources, which is not just at an institution level. It's not just the interaction that you have with the security guard when you show up at your doctor's office, or how you think of yourself as you dress and you leave for the day. It's how society receives you and how this perpetuates health inequities and equities, right? Okay. So back to the Hispanic or Latino monolith, right? So I said, we're not a monolithic people, and that there's a lot of different and diverse histories that happen. Within the United States, we tend to overlook the fact that there are historical and contextual considerations in the social construction of race and ethnicity, meaning that race is a social construct. It is something that within the United States, we understand race a certain way, right? If someone is phenotypically, or their skin color or their facial features look white, we might perceive them as white. If someone is phenotypically, their face structure or their skin color is Black, we may perceive them as Black. Similarly, Asian, Native American, so on and so forth. But if we were in a different country, we may grade people differently into a racial or ethnic grouping, right? So when we talk about social construction, it has nothing to do with biology. If you cut us all open, we all bleed. There is air in our lungs, there is blood in our veins. There is no predisposition that happens based off of your phenotypic features. It is very socially constructed. And so we need to start thinking about measurement if we're ever going to address health equity. And one thing in public health we don't talk about, and this is very well established within the social sciences, within the humanity, is that there are contextual considerations to how race and ethnicity have been constructed within the United States. So it took me until my PhD to understand that we live in a settler colonial state, which I think I was 27, right? And so when we talk about a settler colonial state, what we're talking about is that the United States first had British colonization, right? 13 colonies. We all learned about it in school when we were little. And during this time, there were experiences of indigenous genocide. There were experiences of the enslavement of African peoples. And there was the experiences of oppression of people who were not perceived as white, right? And the settler colonial state continued on through the American Revolution, right? It's settler because it was once a colonial state, and then the peoples who were in those colonies settled that state, removing themselves from the ties of the British government. And so within the state, the creation of laws began and favored what was a Black-white binary, right? The oppression of Black peoples and the privileging of white peoples. And much of our and the othering of those that fell outside of the category phenotypically, right? And much of our policy today still follows that black-white binary, even our statistical policy, right? If you look at, we're going to talk about the Office of Management and Bureau Statistics, statistical standards, right? You have your Black grouping, your white grouping, and then under race, you have ethnic identities as racial groupings, right? Asian, Native American, Indigenous, Pacific, or Alaska Native, Pacific Islander, and some other race, right? Those are our 5 to 6 racial groups that we have on current standards. And so when we think about race within the context of the United States, we typically group people this way, the way that race has been conceived over time. Whereas when we think about Iberian colonization, what happened in Latin America, it was much different. I say Iberian because it's inclusive of not just Spaniard colonization, but it's also inclusive of Portuguese as well as French, right? And so what happened in Iberian colonization is much of the colonizers' playbook was taken, but also there was this Spanish casta system that was installed. This genocide by reproduction, the encouraged forced racial mixing of Europeans with African and indigenous peoples. And so a social hierarchy was created, right? You had whiteness or Europeanness at the top. In the middle, you had mestizo, or the mix of indigenous and European peoples. Mulatto, the mix of European and African peoples. And then at the forced bottom, you had indigenous, African, and lobos or zambos, which were the mix of indigenous and African peoples, right? And this hierarchy favored closer to whiteness, and those by color being more oppressed, right? And this is something that's kind of continued on within Latin America in the concept of colorism. There is a social grading that happens based off of your perceived color, right? And so conceptions of race and ethnicity in Latin America, between countries, within countries, between communities, they vary greatly, right? And so when people are introduced into the United States system, into boxes that ask you to be Black or white, where you may not have been Black or white before, or your ethnicity may not have been placed in the way that it has been placed here, it starts to create mismeasurement and it starts to create confusion, right? And I'm going to go into it more, but about 44% of Latinos in the 2020 census did not check a race. They checked some other race alone, right? And we're going to go more into the OMB standards of measurement, but there's a lot of contention around the new standards as well as the old standards, and there's a lot of things that we're not really answering. And it's difficult. In public policy, we call these wicked problems. They're problems that are very hard to solve. They're built over time. But when we're thinking about racialization and ethnic classification, in measurement, we grade race and ethnicity differently. Race is different than ethnicity, right? An ethnic grouping is about people with shared geographic origin, heritage, and language. So when we think about Hispanic, we usually think about people who speak Spanish. When we think about Latino, we usually think about people who speak Spanish or Portuguese or a language found in Latin America. We think about the geographic location of Latin America, and we think about heritages like Mexican or Dominican or Chilean, and so on and so forth, right? But they're different. We're measuring two different things. We're measuring race and ethnicity. And ethnicity is a multidimensional category, and it intersects with race through both those individual attributes, but also in relation to place in social hierarchy. So in relation to a person's race, right, how they're perceived within the United States, I would probably be bucketed more as white. Their gender, their identity, their sexual orientation, their socioeconomic status. There are so many layers to ethnicity. And it's not just exclusive to the Latino population. It's throughout all populations. So the process of racialization describes social meaning and privileges assigned to people according to these characteristics, right? And it ushers the classification of people into minority groups or minoritization, which basically is saying that, like, despite the fact that Latinos are the majority minority, despite the fact that Latinos are set to become a majority race, I'm not convinced that they will never not be a minoritized class, right? And so when we think about race and ethnicity, we need to start thinking about the complexities of ethnicity, because ethnic identity encompasses so much more than someone being grouped as Latino. Because when you close your eyes and you think of a Latino person, that person probably looks a little bit different to each of us, right? And so when we're focusing on these ethno-racial disparities, we need to think about racialization as a process, not just racism. When we're focusing on racial disparities, definitely racism, because it's very phenotypically based. Laura Gomez says, to count, we must be counted. And there's so many issues with measurement right now. But a lot of measurement within the US, especially on administrative and health data, follow the Office of Management and Budget Standards. And so prior to March 28th, 2024, we used to measure folks with two questions. The first one about ethnicity, whether someone is Hispanic or Latino, yes, no, and then someone's race. And I think the first time I ever saw this question, it was when I was about 7 years old on my Terra Nova test. And I went through and I look at the first box and I'm like, got this. I'm Mexican. Yes. And then I got to the second box and I can remember having a very visible meltdown in class and being like, I don't know my race. My dad's white. My mom's Mexican. My mom tells me we're Mexican. I don't think I'm white. I don't know what I am. Right. And just like them having to call my mom and have her come because like I just totally lost it. And I think it's a lot of what we all feel from day to day, especially when you don't see yourself on a bucket or in a form. And it leads to measurement and measurement error. So we know on the 2020 census that there was a lot of undercounting that happened. About 4% of Latinos in the United States went uncounted, which is huge, especially in districts and areas that have large Latino populations. Like if you think about the southeastern United States or the southern United States and places like Texas, if you're looking at a population size of, let's say, 1 million people and you miss 4%, that's about 40,000 people. And it impacts things like representation in the House of Representatives. It impacts people's ability to advocate and political autonomy. It also impacts things like education funding, what funding is going into what district, because we're missing people and we're missing counts. It impacts federal funding allocations in terms of social support. So your SNAP packages, your Supplemental Nutrition Assistance Program, or what we call food stamps, right? The allocation that's allotted out to certain areas of the country. And it also impacts access to healthcare, right? And the barriers that exist and persist and what people are there. So we also know that this doesn't just exist on the mainland. McSorley et al. Found in their 2023 study that there are major gaps in the US public health monitoring and surveillance system, specifically in the archipelago of Puerto Rico, in the island territory of Puerto Rico in the United States. And they found that the monitoring system totally missed data around health of Puerto Ricans chronically, right? And this is an issue. It's a big issue when we're thinking about identifying public health interventions, when we're thinking about how policy is allocated, and when we're thinking about what resources are needed and where. If you look at the ethno-racial groupings too, it's really interesting. So this is from the 2020 decennial census. I just did a quick screenshot from the population profiles yesterday. And it's interesting. So if you look at race alone and one race, you see that There's about 11% of the population that's unaccounted for, which is interesting. 8.4% of people are some other race alone. 10.2% of people are two or more races. Oh, no, that 10.2% is two or more races. We see that, like, you know, white folks still maintain a majority. We have about 12.4% of the population in the 2020 census are Black or African American. And then you have this totally diverse category down here of Hispanic or Latino, right? And this is the 2020 census. We're going to talk more in just a few slides about the new rule revision, which is aimed at data completeness. So we know that 44% of Latinos or Hispanics on the US Census in 2020 identified as some other race, which basically said that we're not counting people right. And the US Census has really understood this among the Latino population as well as other populations within the United States, that there are pervasive undercounts, there's a lack of representation, and there is a low response rate. And so in 2023, they began to hold focus groups, they began to hold town halls, and the Office of Management and Budget in January, I believe, of 2023 proposed new rule revisions, which were then passed on March 28th, 2024. And these rule revisions basically said that we're going to combine the categories of race and ethnicity. So Latinos, if you look at the federal definition, are still the only ethnic group within these race or ethnicity buckets. And then there's the new Middle Eastern or North African category, which I went rounds looking through this policy, and I can't identify how Middle Eastern or North African, or what we call the MENA category, is identified, if this is a racial grouping or an ethnic grouping. But from what I can understand, it's a race or ethnicity category. So that's really interesting to me. And so our new forms that we're going to start seeing on the 2030 census and rolled out over time is, this is an example of the form, but you're going to start seeing this detailed race and ethnicity data collection. So you'll have your groupings of white, Hispanic or Latino, Black or African American, Asian, American Indian or Alaska Native, Middle Eastern or North African, and Native Hawaiian or Pacific Islander. Right. This is really interesting of a revision. I'm not sure. I need to double check this. It didn't really occur to me yet, but I'm not sure if the other grouping will still be in there, because I assume that other people will still not feel as though they identify under these buckets. But this is the new OMB revision, and it'll take some time for it to start trickling down, where you'll start seeing it within other forms and formats. They're still piloting it and testing it to see how this would be applicable. But it's going to change the way that data are collected. But we argue in our paper that data completeness does not mean representation. Not everyone is going to feel satisfied by these buckets. I was on Twitter after this happened, right? And the Latino community is extremely diverse. And so there is a lot of concern here, right? Like, when you're asking someone to pick just one box or many boxes, are people going to start self-selecting into an identity that feels more, not privileging, but an identity that allows them to distance themselves from less desirable categorizations or more desirable categorizations? Is this going to advantage some folks or disadvantage some folks? And is it really truly representative of who's out there? And this is honestly strides better than what we've had in the past, but there's always more room for improvement. Okay. We also know on other health surveys, right, we don't always all follow the OMB standards, but on other health surveys, data are collected in many different ways. Zambrana et al. Did a study of 101 existing data sets ranging from health data sets ranging from 1960 to 2019. And they found that some surveys had some multidimensional aspects, so around immigration factors or race and mixed race measures, age and sexual or gender orientation and identity, but most had significant gaps in data, which limits our ability as researchers to analyze and find health disparities, but it also limits the abilities of folks at county or local levels who are trying to identify disparities and really target and think about what's going on. There's also some other issues too with underreporting. Data suppression happens. In 2022, I was on a consulting project with CDC funding, and we were trying to find different disparities based on ethno-racial groups throughout the United States. And more often than not, especially in rural communities, we could not get a count on Latinos within the US and the disparities that were happening within COVID. And that partially was because a lot of health departments will suppress data if they don't have so many observations of folks, right? And that's partially because you want people to live a private life. You don't want to be able to be like, okay, Mary, she lives in Philadelphia, and there's like 4 other Latinas in Philadelphia, so definitely one of them is Mary, right? We don't want that to happen. But that also means that we know that undercounts happen, and so we're not able to see what's really, really happening with inaccurate measures. I think Kelly's going to talk about a few case studies that happened, but we also have to think about like accuracy of our forms and our data that happen in our collection day to day, even on the street. So if you think about it, if you were raised in the United States and in the United States schooling systems, the way that we learn date is month, day, year, right? But the way that other people who may have gone through schooling or raised in different cultures may start talking about date is date, month, year, which can be very hard when you're thinking about things like COVID-19 vaccination cards. And when was it that you got vaccinated? And now you're filling out health forms, and like these health forms have different varying dates, and it might impact the sequence that's happening in your vaccination status. It may impact people that are following up with you, or it may become that you can't verify health data in an emergent situation, right? So we need to think about strategically how we're presenting out and thinking about forms. So some things to think about when you're collecting data, and a big thank you to Kelly, because Kelly really helped with this slide. Thinking about the instrument itself, right? Is it cross-cultural? Is the population in front of you going to understand the instrument that you're presenting? So when we say cross-cultural validation, have you piloted it with folks that you intend to talk to? Are people going to want to fill this out? Or are they even going to understand the examples or the ways in which you're framing questions? If you're with a population that may not have English as a base language, are you training interpreters to give these surveys? Are you answering questions? Are you going over it with them in detail? Like I said, piloting surveys and testing for accessibility. So is your language, accessible? Is it good? When I was working in community health, we figured out that using the word produce instead of fruits and vegetables was limiting in access and in how we talk about things, right? So making sure that your language is really towards a community and towards an understandability. Partnering with your community-based organizations. In my own work, we partner with a lot of community-based organizations because honestly, academics, we get it wrong a lot. And we don't talk to real people often. And so we need people who are on the ground. We need organizations who work with populations day to day, one, to help us think about the questions we should be asking, help us think and inform about how we should be measuring, and help us think about what will actually advance health. I didn't get into the research game just to sit here and sit in what they call the ivory tower and do work that only 4 people actually are able to care about or need, right? I think that the goal of most of us is to really have meaningful work that's going to start making pieces towards health equity or getting everyone what they need where they need it. Also working with community health workers with promotoras. I know that there's so many issues with the funding structure right now within Medicaid and reimbursement structures, but you know, people who come from the community, who speak the community's language, who are able to translate tools are so integral in canvassing efforts, in the ability to really truly meet people where they need to meet people and to get accurate health data. Because our first strides of health equity are really understanding the health needs of a community. And that happens at the door-to-door level. It happens at the community level. If you're using things like, oh, that was a slide from another presentation. Sorry, everyone. There's been a few this week. If you're using things like secondary data and health statistics, you need to think about the biases that exist with the survey creation itself. Many surveys that are taken off of other research might not be really addressing the population that you're thinking about in total, right? Best practices generally aren't the best practices for everyone, right? There needs to be tailored methods towards the population that is in front of you. So if you're reading through a question and you're like, who wrote this? Adapt that question. Make sure it's like going towards the community that you're really going towards, or make sure that the language is accessible towards the community that you'd like. If you sit around my family's dinner table and you say the word Latinx, one of my tias will quite honestly yell at you. She's like, I'm not Latinx, Mary, right? And so she got a survey that said like, are you Latinx? She would be like, nope, bye, right? So you got to culturally tailor. You got to think about who's in front of you, not to off-put people. You have to think about too, the biases that exist within data collection. I think so often when we look at US data, we're like, oh, this is great. The census reaches everyone, and we don't think about the undercounts. And the undercounts happen across the board, not just within the Latino population, but also within the Black population, within the Indigenous population. And when folks aren't counted, they're not represented. And also within health statistics, right? I showed that example of infant mortality rates and how we see that Latino women and white women have almost 1-to-1 infant mortality rates with births. But then when we start disaggregating the data or taking the data out by origin group, we see actual health disparities emerge. So we need to interrogate what we're actually looking at and who our population of interest is. So better analytic approaches, use ethno-racial variables. If you're talking about Latinos or Hispanics within your racial groupings, that's an ethno-racial group, right? You're talking about race and ethnicity. You can also think about how you present out data. I've rarely seen it done, but I like it when I see it done. You know, if you're looking at like an ethnic identity and a race and you have both information, could you present out on who is Afro-Latino or white Latino? Or, you know, if you have ethnic identity too, could you represent out who is white Asian or, you know what I'm saying. Can you break this apart and can you make meaningful understandings of the data, right? And I will go back to this over and over again. While we're focusing on the Latino population, this is applicable to so many different populations in the United States that have health disparities that are masked. Data disaggregation is just fancy for, can we look at it by different groupings, right? Can we look at it by what I was just saying, by race? Can we look at it by gender, right? Can we look at it by age or nativity, US born, non-US born? And what does that tell us about the health disparities that emerge? This is really difficult to do. So you have to be really focused on who your population is and the question that you have at hand. Because if you disaggregate or you look at it by every single thing, then it's going to be overwhelming and you're not going to be able to like tease out what you want to tease out. So a focused question on a focused population and the context you're looking for, right? If I'm trying to understand I'm sitting in Newark, Delaware right now, Latino health disparities in diabetes, I'm probably not going to use national data of every single person, right? I'm probably going to try to find a data set that's closer to Delaware. And I'm probably going to try to zone in on the Latino population of Delaware and look at origin group or racial identity or age and see what patterns emerge to look at how I can serve my community, right? Looking at like anthropological approaches are really helpful too. So instead of telling someone check your box, ask them how they define themselves, right? See what they would say about themselves. If you sit around my family's table, someone might call themselves Chicano or Mexican American, someone might call themselves just American, someone might call themselves Latino. It really changes. And the way that I say it to my students and other researchers all the time is it's not our job to tell someone who they are. It's our job to ask someone who they are and then figure out how best to accurately represent them in research in order to better help and better advance different types of interventions and disparities. So I'm just going to end with this. Through different methods, right, and better practices, Latinos can be represented, and we can really understand health disparities and what we need to be doing to push the dial towards health equity. So thank you all so much. This is my email. If you want to reach out, you're welcome to. Kelly, it looks like we have a question, but are we doing questions now or saving to the end?
Yeah, if we can just save questions to the end, just as we're going to be transitioning into the case studies, please hold your thoughts, or you can put them in the chat, just so we can keep track of questions, and we'll get to them as soon as we're finishing up. So thank you so much, Mary, for this wonderful presentation. I think in another life, I would have been a medical anthropologist. I absolutely love anthropology, and it really gives us more of the social context around where we're at today. And I hope others can join me and Mary on these kinds of journeys of understanding context. And really, when we think about root causes, this is what we're talking about. Like, what is the intergenerational root causes of what we're seeing today? So we're going to transition into some case studies, just really segueing into the conversation that Mary was shared around what this looks like on the ground. So something that I appreciated that Mary shared is that Latino invisibility. So research showed that, while Latinos were invisible during the pandemic, especially during the onset of the pandemic. But when we look at our populations, Latino populations are actually also really young. And so while they're young, they were actually completely ignored when it came down to sickness and illnesses regarding of what they experienced during the COVID-19 pandemic. What wasn't integrated is the fact that they are essential workers, and they did not have the ability to take time off. They had to be in the field. They were likely undocumented, so they had to work kind of these informal jobs that required them to be at the front lines on a constant basis. And so those are some of the things that we're going to be talking about. They have some case studies that we experienced through MLU around how we supported some of these communities. And so I will always reiterate around the aspect of community collaborations and how we can really think through what boots on the ground data collection looks like. So during the pandemic, we were able to establish the Mid-Atlantic Latinx Vaccine Equity Coalition, which included many partners across the state of Maryland, to look at what was happening in Hispanic Latinos during the COVID-19 pandemic that wasn't really talked about in the news, or wasn't talked about in media, or wasn't even having research come out, or conversations or dialogues around our Latino community experiences. And so we're very thankful for all the partners that work with Maryland Latinos throughout this time to be able to really think about what data collection means for Latinos during the COVID-19 pandemic, and how we can continue to build upon those infrastructures now that we're looking at Latino and Latina communities from a health equity perspective. And so I'm just going to give about 2 case studies on some examples that happen. And Mary, I'm so glad you brought up about the COVID-19 kits, because that is something that we consistently saw in our communities. I don't know how many of you saw this, but also in tandem with the fact that they were only giving 2 COVID-19 kits, the instructions weren't in another language. And so something that we were seeing a lot, especially in intergenerational homes, where you had la abuela, the tia, the cousin, the best friend, or the person from your home country that just got here, they were all living in one apartment. And so Something that we did was we partnered up with our local health department to really think about what tailored COVID-19 kit distributions looked like. But not only that, we were collecting race and ethnicity data that really was the hope was to represent our community better and understand what tailoring our services look like for the community. And so during this time, what we did is we worked with local health departments and also federal initiatives to do outreach to local partners such as food distribution, faith-based organization through social media, not this kind of grab and go method. We were able to provide COVID-19 kits at Title I schools through the school-based health centers. And so again, as I mentioned, they didn't come with instructions in other languages. And so what we ended up doing is we ended up creating videos and accessible language tools to be able to inform communities about the COVID-19 rapid kit, how to use it. Because I promise you, when I looked at it, I felt like I was reading an IKEA instruction booklet. And I only say this because my husband and I just built an IKEA shelf the other day, and it was really complicated. But at the same time, what was also happening, because these COVID-19 kits were coming, people weren't going to clinics or these sites to also get tested for COVID-19, which is what was the state health department and local health departments were using as data to be able to showcase how many people were testing positive or were testing negative. And so what was happening is when they would test positive, they would not report this information to their state health departments. So what we integrated in this project was we also helped our communities go into the Maryland Department of Health portal to be able to report their results, so it can be included within that overall data set to have accurate representation of what our community was experiencing. And so what we did is we trained our community health workers, that are boots on the ground. And so I will always give a shout out to Glenda. Glenda was one of our community leaders that was, who was and is from the community that we were serving. She knew everybody, the ins and outs of the community. She understood the context and the people that were living there. And so she also represented the predominant community that is in there. As you can see, 22% of the folks that we provided COVID-19 kits to were from Guatemala. So a really majority of the population that we served was from Guatemala, and she was from Guatemala. And so what we did is we trained our community health workers on how to use a COVID-19 kit. We also trained them on how to collect this information, especially at school food, the food distributions, because it was also like, they're trying to get their food. How do we overlay that workflow and make sure that it doesn't cause any delay in terms of people getting access to food? And so we were able to distribute these COVID-19 kits, and we also did follow-up calls. So we did online kind of these virtual visits. So people would call our CHWs through WhatsApp, do a video chat just to see how we can follow up and make sure that they're able to report those finding their results, but also how they're able to use the kit at home. And so something that we also found, while a predominantly large of our community spoke Spanish, some of them actually didn't know how to read. And so while they know Spanish, while they can speak the language, they didn't know how to read. So here's a quote from one of our CHWs. She's a 70-year-old woman who did not take the test, but I helped her do it over the phone, giving instructions since she doesn't know how to read, but wants to take the test. I spent an hour talking to her to help her do it. And so these kinds of connections and being able to establish and building these trusts with the communities also helped us in terms of our data collection. Being able to have representation of communities, being able to ask these questions around how do you identify, what is your country of origin, what language do you speak, being able to ensure we give the autonomy and empowerment to the communities that we're serving to self-identify who they are, and how we were able to tailor our services to ensure that it met them where they were. And so some of the things that we also just kind of as we're that cultural context and what that means is connecting with the communities, building that trust, but more specifically, tailored communication, that sharing of experiences, sharing of where you're from, understanding their ethnicity, understanding their country of origin, first gen, second gen, third gen, what their experience in this country looks like, obviously language. So I like to give this example because it's, we often find ourselves having to translate documents, but a lot of times, even within the Spanish dialogue, there's specific ways how we use our language. So in Mexico, when people say aguas, if you were to put that in Google Translate, aguas actually means water. But the context that comes behind that is Mexican communities are saying be careful or watch out. So if you hear somebody say aguas, aguas is because they're telling you to be careful. For example, in El Salvador and Nicaragua, the word bicha or bicho means boy or girl. In Puerto Rico, it's actually not a good word that you should not be using, right? It's actually, there's you can look it up. But, even within our countries, there's like these cultural contexts of how we use language and how we speak. And so in Venezuela, chimbo means disappointing or poor quality, right? So within these, when being able to look at our communities, not from that monolithic lens, we're able to really look at how we're able to develop services, tailor our communications, and be able to have conversations with communities when we understand where they're from and how they self-identify and how they speak their language. And so when we were having those COVID-19 virtual visits, that really helped us understand where the community was coming from, what their experience were, how we're able to not have, like even within Spanish, how we're able to ensure that communication is not broken when we're using some of these language or terms that may not be familiar even within our own cultural context or where the countries we were from. And so being able to have that data also helped us have these conversations with communities that we were working with. And so the second case study is actually from the city of Annapolis. So one of our partners who is actually now, she's at the comptroller's office, Laura Gutierrez, really spearheaded this effort. And so she developed a health education outreach program. And so what she did is she hired Latin American health professionals who unfortunately were unable to access jobs, even though they're health professionals from their countries due to their legal status. And they actually came on board into the program to do canvassing around their community, to be able to reach Latino and Latina communities where they work. And throughout these conversations and throughout these canvassing and being able to have a representation of community members that looked like their community, that spoke their language, that were able to have these dialogues with them without feeling like they didn't know who they were talking to, they actually found that data that was being reported actually was misrepresenting how many Hispanic Latinos were in the community. And so being able to have these boots on the ground community health professionals and folks that are really understanding how to really use these survey instruments and tailor them within the context of the community, it was able to showcase what the community actually looked like. They were able to reach vulnerable communities through their health education workshops, through flyers and marketing, and were able to really support communities, not just from the COVID-19 perspective, but through health fairs, through resources, and being able to connect them and navigate those systems that they're currently in. And so, again, they were able to identify Hispanic and Latina communities that were previously not represented in some of their data collection, which ultimately impacts how kind of these folks from health departments or like academia, or like if they were to see these data trends and they saw the example that Mary mentioned around infant mortality, it was actually misrepresenting the COVID-19 impacts that our communities were facing on the ground. And so when we think about tailoring our services, when we think about developing our programs, how do we intentionally do that to ensure that the voices of our communities are not misrepresented in some of the data that we're collecting? And so again, through this canvassing method, they were able to develop a survey instrument where the canvassers were able to go out, knock on doors to the community to be able to ask these questions in a way that give the empowerment and autonomy back to the community member. And so here's the website if you want to take a look at the program a little bit more. But just wanted to give some final takeaways around this conversation. And we definitely want to get into questions and have an open dialogue around the kind of both things that you heard today. Was understanding who is in your community through data collection. I think that is kind of resonates with many of us. And what that means also in terms of the workforce that you're hiring, in terms of the people that are on your program, the people that are helping you develop the program. How are you being inclusive to ensure that there is appropriate representation of your community in your programs? What are the tunnel visions that need to be broken down to be able to understand the full perspective of what data collection actually looks like for Hispanic and Latina communities, and what the intentionality behind all of that is. And so also diving into the root causes of this intergenerational context within your communities. And so what that means for improving your public health programming, and again, looking through the survey instruments that you're working on, and training for boots on the ground. This is something that I'm very much a big advocate for. Our community health workers are really the voices of our community and can fully represent the communities that are that they're serving within your programming. So being able to train them to be able to have these conversations and understand the cultural understandings of the Latin American experience. And also reviewing the OMB revisions. Is this something that makes sense? Is this, how can you tailor that to ensure that it reaches your community? So now we can, I will stop sharing my screen just because I feel like it's much nicer to see everyone. If you wanna come on camera, if you feel comfortable doing so, but we definitely want to answer some of these questions that you all may have throughout the presentation today. And so I did see Tylene Carver. I don't know if you're still on.
Yeah.
Okay, awesome.
I had a question while you were presenting the new measure on race ethnicity. I was just curious if it will continue to be a check all that apply. And I think it was based on how it was featured, but I didn't know if you, okay.
Yeah, sorry about that. It should continue to be check all that apply. The only question I had, because I hadn't really stared at the example box just yet, which I can look into more, is if the other box will still exist, right? Because they were trying to data completeness and data accuracy. Those were the measures that were going forward for, but it's unclear to me if the other box will still be there, but also, no, that makes sense. Okay, so OMB is different than the US Census. So the US Census has some other race on it. The Office of Management and Budget Standards, this is what the US follows in terms of different divisions within the federal government and how they ask people and how ethno-racial groups are presented in data. So it makes sense why the other box wouldn't be on there. But yes, check all that apply should still be on there. Yeah. Kelly, should I call him?
Yeah, Alexa, I see your hands up. Yep, I'll go ahead and call Mary. Don't worry.
Thanks.
Hi, this presentation has been, wait, do you hear me? Okay, this presentation has been amazing and it's very relevant to my dissertation work. So I'm actually looking at birth outcomes among Afro-Latinas in Florida and comparing them to other racial and ethnic groups. And I think one of the issues I am having when I'm putting out, like I tried to put out an op-ed about Afro-Latinas being represented in maternal and child health and looking at the disparities of Black mothers, because we know that there's a big disparity among Black mothers. But an editor recently was kind of going head to head with me about the Afro-Latino identity and pretty much, I don't want to say the word gaslighting, but I felt gaslit into thinking that Afro-Latinos are not Black, and that I'm misrepresenting this community by saying that they're Black. And I think this editor maybe has this, I guess, perception that Black means African-American and Afro-Latinos are not African-American. And so I kind of get that. And I think that seeing this new form, it's like, when we say white, we just say white. But when we say Black, we say Black or African-American. So I think that that kind of adds to the confusion. So I guess my question is I'm doing a secondary analysis and of birth certificate data, and I'm looking at people who identified as Black and Hispanic, and I'm saying that those are Afro-Latinos or Afro-Latinas. Is that considered misrepresentation? Should I not be using, because I want to add to the literature for Afro-Latinos, but now I feel like Is that wrong? Should I not be using the term Afro-Latinos? I kind of feel a little stuck right now from that experience. So I kind of wanted to hear what your thoughts were on that.
Yeah. One, it's an incredibly difficult question to answer, and I admire you for going for it, because I've heard a lot of different things within the Afro-Latino community. And I think Pew Research, they had some statistics that came out around Afro-Latino identity, in that like some folks like to be considered as Afro-Latino, or also Black and Latino, right? Like, and I can't speak to the topic well enough, because I'm not going to lie and say I'm an expert here, because I'm not. I think it's really complicated in that the identity isn't also necessarily like rooted in just in origin country, but it's also within the United States itself, right? Like you could be you could have like a parent that may not be Black and Latino or Afro-Latino, and another parent that may be Black, right? And so you might think of yourself as Black and Latino, or you may have parents that identify as Afro-Latino, and then you as well identify as Afro-Latino. So I think it's like super complicated to disentangle. And I think maybe it's just like, I don't know, maybe it's the Afro-Latino / Black Latino thing, and, you know, a line or two explaining that like these identities are not one thing that I've started to do in my own work. Because I used to just be like Latine, Latinx, right? And it became very isolating to certain people who don't identify that way. And I would always be like, well, don't call me by my colonizer, right? But there's like this comfort that some folks have in being called Hispanic, and we can't ascribe identity to people based off of what we think a term is best to be. But it's also hard when you have like a 750 word count, right? And it's also hard to really unpack and disentangle it. So I don't think I'm doing a great job at this, but from what I've seen in the literature is that it's very much an area of still folks are speaking to folks trying to figure out what this means, because very much within the United States, being Black Latino or Afro-Latino, we receive people by their street race, how we perceive someone to be. And so our experiences of health, our experiences of discrimination are very much on how we're received at the street, not on what form or box I identify with, right? And so it does matter. And we do know that like, if we're looking at origin groups, right, we can see that origin groups that typically come from the Caribbean that had, there are Afro-Latinos throughout Latin America, right? But major histories of the North American slave trade coming through, or major histories of African and indigenous populations within these countries of origin, right? We can see worse health outcomes, especially in infant mortality. And so it gets complicated, but like it is so masked in the monolithic data. And so I think the work that you're doing is like so important. And I believe we wrote a paper together with Cynthia on this. So you're actually my expert on this work. And I'm excited to hear how it works out, but I'm happy to talk it through if you ever want to talk it through.
Thank you. I appreciate it.
Yeah.
Thank you, Alexa. And I see Lisa's hand up.
Hi, great conversation. Love this discussion and everything. And the previous question was actually, I was thinking in the new OMB standards, like there's going to be a lot more of the two or more identities, right? Race identities. And then you're going to like be filtering out those Black Hispanics from the Hispanic category and from the Black category. And how does that impact, you know, our ability to track things? So it's really interesting. But actually, this morning I was speaking to a client. I work often with parents of children with disabilities. And so I was asking the mother about the child's race or ethnicity. And I used the general question, what is the child's race or ethnicity? And she started going into that whole conversation. And she was like, at first she was like, well, my husband and I are Chilean. I'm more white, I guess, appearing, and my husband is darker, you know, and I was like, well, we don't really have a mestizo category here, so like we can't, you know. And then I just asked her outright, you know, if you had to answer on a form, is your child Hispano or no Hispano? You know, do you consider them Hispano? And she said kind of reluctantly yes. So then I was like, well, if she doesn't identify him as Hispanic, but she's identifying him as Chilean origin, then do I just mark the box Hispanic on that OMB, you know, the new standards, because Chilean would be considered within the Hispanic category, right? So anyway, it's just, you know, you encounter these issues all the time. It's very complicated and you have to just do your best, right? It's not really a question,
Absolutely.
but just wanted to share that.
No,
I
but it,
had a very similar experience with when I was working with a lot of the Venezuelan migrants that just arrived, that were being bused here from Texas. So a lot of the things that we had to do was also do these kind of intake forms. They had never seen this question before. They just got here like, you know, a couple days ago. And when I asked the question, he was like, I don't know. I think he's like, you know, I'm very darker skinned. I'm from Venezuela and I speak Spanish, but like, what is, so, I mean, it was kind of like, for me, I did very similar to Mary. I had a very existential crisis. I'm very white passing and acknowledge that privilege as a Latina, the privilege that I have compared to the communities that are Black and Brown communities that are Hispanic, Latino. And so, you know, for him, it was kind of like this moment of like this first time he was like, I have to identify myself based off of my skin color this way that I'm, you know, on a form, like why? And so these are the challenges that a lot of our communities face. And I think, I mean, you can do as much training as you want. I think this is always going to be a topic of conversations, especially when kind of this, what Mary was saying around the social construct of race and what that looks like around oppression. Like, you know, I think this has to do with also like how we integrate these conversations. And also, you know, I love how you explain like how you know, were going through that dialogue with the community member, you know, how, you know, what is, you know, I think those conversations make it a little less stressful when we look into these kinds of things. And so I really think this is, you know, an ongoing conversation we're going to have because you know, there isn't a right or wrong answer. I think it's more so from the lens that I'm coming from is how do we empower our community to self-identify who they are and how they identify, going back to that context around, we are not here to put a label on you and we will not be putting a label on you from our perspective. How do you identify? How do you have these conversations? And that's how we tailored our survey instrument. But I know grantors and how they ask for data and information that's also very dependent on how we do it. But I very much share our sentiments. Share that sentiment. And Mary, I'm sorry, I think you were going to say something.
no, just ditto, right? I think Kelly, you said it so eloquently, but it's just, it's so complicated, and it's so complicated when your identity falls outside of what the bucket, right? The bucket that we as Americans put people into, or even right, like I've never felt exactly white, but I will check the white box because of the privilege of my skin color. And even at work, in order for me to submit a grant to a federal granting agency, I have to check a box. And I had HR tell me, like, you could always check American Indian, because technically, like, Mexican Americans are native. And I'm like, now I'm claiming someone else's identity, and this feels gross. So I'm just going to check white, right? But there is no other box on that form. And when there is no other box, where do you check? And I'm extremely white presenting. So of course I should probably check white, but it still always feels just a little bit weird to me because I never feel exactly white. So it's weird, right? Like it's always weird. And I think especially as like clients and folks grapple with it, and the reason why I brought up the histories of colonization is like, we don't think about it, right? Within our own community, within other communities, about like how these things affect how there is colorism that is pervasive in our own families. Like when I was little, like I was very acknowledged as la güerita, like the little white girl, right? And there was like this grading, or how like brown you are, or how black you are, you know, these different aspects of identity that are ingrained with you, but you don't see reflected when you come up to your first administrative box without your parents telling you which one you're going to check. Yeah, I don't know. It's so weird.
Right. And does anyone have any other questions, comments, or experiences that you all have shared? And I've seen, thank you, Alessandro, for sharing your experience with the survey instrument. But we have about 4 minutes left, and just wanted to see if anyone had any additional comments or questions.
I can share another example. I also work with a lot of the Asian community, and there was a man that I was working with who, when I asked him the race, and I said specifically, you know, what is your race and or ethnicity? And he said he was white. And then I later learned, like many conversations later with him, I learned that he was an immigrant from Iran. And I was like, oh gosh, well, if I had known that, like, would I have marked him as Asian, right? And then like now with the new categories, would he be Middle Eastern or North African, right? So like you have people who are accustomed because their mother told them you are white, right? Or whatever the situation is. Or just like we're used to checking that box on the form because that was the only box that matched them at that time. But maybe, you know, and I still haven't figured out how to categorize him. I think I still left him as white, but you know, it's complicated.
Yeah, absolutely. I wonder how many times, if you look at one person and how many different backgrounds or origins, I guess if you do like some sort of like survey collection of all of their previous surveys, how many cultures they've gone through their process in time. So especially with these OMB revisions, also like what is that going to look like? But yeah, no, thank you for sharing that. Any other final thoughts? Would love to hear from others if anybody has any additional comments or a question.
Excuse me, can you hear me?
Yes, we can hear you.
I just have, I don't know if a comment or just something that I've kind of struggled with, seeing as I'm sorry, I don't have my camera up, but you know, fair skin, Puerto Rican, and my aunts, my own mother, you know, they're more of what you would consider Afro-Caribbean, and something I've asked them before, you know, like what would you put down on that, you know, when they ask you that question, and something that I've heard from them and other family members and friends that look more like them is, and something that I've noticed is that there's like a lot of racism within our own, you know, community, and you can never dare say that they're Black, you know, and
Yeah.
they take, you know, much offense to that. So I feel like that also, you know, impacts how one answers or perceives that question, or who asked that question or how they're going to answer it. So I think that's something that I struggle with a lot, and how, you know, to identify those in my own family that have more of those traits and look completely different than me, even though it's just my aunts or my uncle or even my own, you know, grandparents. So yeah, I just never know how to help them categorize themselves into that. And you know, keeping in mind that a lot of, you know, those in our community do have like that racism in regards to certain races that they would fall under.
Right. I can just tell you from right now, like that is just a predominant, you know, unfortunate conversation we have to have. Like if you put all of my siblings, if you line us all up, we are just so many different shades. And when we have this conversation, it's like, you know, I know that they're, you know, it's like, oh, you know, she got the light brown hair and she got, you know, and then where my sister, she had like these curly Q hair, like black, thick eyebrows. And she felt so unseen because her mom and her dad look completely different than her. So she's my stepsister. And it was like, she was having kind of this crisis of like, what am I? Who am I? Like, why do my parents look completely different than I do? And like, then you also have those like privileged conversations of people who have fair skin, like, you know, it's like there's this classism within colorism that happens within our context, that within our communities and our families, that just needs to be unpacked. And you know, I try to have this conversation as much as I can with my kids, because they also have different, you know, skin tones. And it's just, you know, I think it's up to a lot of us who are here today that need to really unpack these conversations, whether they're uncomfortable for them. I mean, but it's going to take a lot of time to really unpack a lot of that. Right, but
And
I
it's
know we're at
spaces
one.
like
Yeah,
this
sorry,
that
go
are
ahead.
so needed. Thank you, Kelly. Sorry.
Yeah, it's spaces like these, absolutely. But I just want to thank you all. I know we're at 1:31, so I want to be respectful of everybody's time. But I just want to say thank you so much for attending today. We will be sharing this link, the recording along with the slides, so you can have that and be seeing that in your inbox as soon as we have everything uploaded. But thank you so much, and please feel free to stay in contact with all of us. We're super excited to continue this dialogue, and we can always have un cafecito or something if you want to continue to have this conversation, because this is something that I know Mary's very passionate about. I'm very passionate about. So just thank you so much for being here today. All right, bye everyone.